Welcome to Issues. We're so very happy to have you with us this evening. And I'm your host, Richard Smith. As always, you can go to our website, issuesbda.com, issuesbda.com. There you will see past programs, and you can even go to our page and send us an email. Tell us what you think of the program, and you may even want to suggest certain programs for us. Well, this evening we have Ann Smith Gordon. And Ann Smith Gordon and pals seem to be synonymous. And we're so very, very happy to have her. Welcome, Mrs. Ann Smith Gordon.
Thank you, thank you.
Now, my first question, what does PALS stand for?
Well, it was a very clever name that Mrs. Vo Crossan thought up way back in probably 1980. And it stands for Patients Assistance League and Service. But it's a bit of a mouthful, so we really don't use it anymore, and we just use PALS. And then we have Cancer Care in Bermuda, so because PALS alone doesn't mean anything to anybody.
That's correct.
So we've stuck Cancer Care in Bermuda there.
Okay. Now, what year did PALS begin, and for what reason? Was it specifically for cancer?
Well, back in 1979, Hilary Soares was working at the hospital, and she saw patients languishing there that probably should not be there, and she got the idea of starting a home care service. And she got together a few friends who went in and would sit with the patients, help feed them, read to them. And eventually, a couple of patients were allowed home with volunteers. In those days, remember, cancer was considered a dreadful disease. People were terrified of it. Still is a dreadful disease, but people were terrified of it. They were even afraid to use the same utensils in their houses. They were afraid to kiss their parents for fear of catching this dreaded disease. So it was very, very difficult. And those patients in the hospital had almost been abandoned by their families. Number one, people were working, so they weren't able to keep them at home, and plus the fear. So that's why they were there. And Hilary thought, well, we'll start PALS, and PALS really began at the end of 1980. And I came in about 2 years later, and that was the same time we got our first nurse, part-time, and that poor sight raced from one end of Bermuda to the other, and it wasn't long before she could not keep up. We got another part-time nurse, and then they both became full-time, and then we went to government and thought we had a wonderful idea and asked them if they would employ or pay for 2 full-time nurses to match our 2 full-time nurses, and they did that in 1989.
So that was 4 then. The
So
government
we had
paid
4,
for 2,
yes.
and PALS paid for the other 2.
Yes.
So.
And then, well, that's the way it was supposed to be. It didn't exactly work out that way. But that government grant we had up until this year. But it never did cover. It covered maybe half of what the real cost is. However, every little bit helps.
Yes.
Every little bit. And now we have 5 nurses.
Okay.
And they're divided geographically, so that if someone's living in St. George's, they don't have to race to Somerset to a patient. So they're all they all have their certain areas.
Now, let me ask, what services the PALS provide?
Well, I think in a nutshell you could say hands-on care of cancer patients at home, whatever they need. If we have a referral, they must be, first of all, the patient must have a diagnosis of cancer, and God knows I don't wish a diagnosis of cancer on anybody, but that's what the first necessity. And then we need a referral from a physician, and usually the oncologist or a GP. Sometimes patients will come in and say, can we help them? Or a family member will come and say, can we help them? And it's very simple. I'll just say, ask the physician to send us a referral. And there's no problem because we're saving them a lot of time. We're saving the hospital beds by keeping people at home. So we had last year the most referrals ever, 148
in 1 year?
1 year.
Year?
Yeah, 1 year.
Wow. So in addition to the 148 referrals that you had last year, you prior to that you had previous patients?
Well, that's it. That's in addition to those already in our care. But then sadly we lose patients too.
Right. So about how many do you have now that you're looking after?
Last week we had 125.
Wow. Now, how much do you charge for your services?
Not a penny.
Wow.
Not a penny. And we never want to charge a penny. And it's very expensive today, especially costs are going up and up and up and up. And people are on more expensive medication, and all the supplies are more costly. So it's difficult.
Now, what is your budget? How much is your budget?
Well, we're going to tell you just about 1.3 million a year.
1.3. And all that is raised how?
Well, we have... Oops, sorry. I knew if I moved, but it's going to fall out of my pocket too.
Out of that.
Okay.
And all that is raised how?
Well, we work very hard all year raising funds. I feel very strongly that we shouldn't be sitting back expecting nice people like you to give us donations and other people to raise funds for us. So we have something going on almost every month ourselves, but there's no way we can raise that kind of money. No way. So we now have an annual appeal letter that goes out. But what interests me, and that there are about 2,000 of those letters that go out, but what really interests me is that the unsolicited donations, the ones that we don't ask for, exceed the solicited donations, which I think is staggering.
Yes. Yeah. I think the services that you offer is quite extraordinary, because from what I know of PALS, whatever that cancer patient needs, PALS try to fill that. Even equipment, from hospital beds to bedside commode, whatever. Now, suppose someone has to go overseas for treatment and they don't have the funds. Does PALS help out with that?
Yep, PALS certainly will help out with that. Again, we need the referral. Mm-hmm. If they have insurance, major medical, the insurance will pay pretty much most of it. But if you're away for radiation 6 or 8 weeks, most people do not have the money to pay hotels up front. Mm-hmm. So we will do that. And then I will chase the insurance company. I never chase the patient. The insurance companies are pretty good. They don't always pay the full amount that I send the bill for, but I would never chase a patient to pay the difference.
Right. So even though PALS will put out the money up front and will submit certain amount of it to insurance, if the patient is not able to cover it, or if the insurance is not able to cover it, PALS will still foot a portion of the bill.
Yep. Well, if they don't have any insurance, they go to LCCA.
Yes.
And LCCA will fund the medical portion only, not the airfares, not the hotels. Mm-hmm. So we do that. As long as I have the proper referral, and I know the LCCA have done due diligence in their research, and so I don't really have to ask a lot of probing personal questions. And we help as much as we can. I mean, it's devastating when you get this diagnosis. It's devastating. Yeah.
Now, Mrs. Ann Smith-Gordon, tell me, what is your role today with PALS?
What, from cook and bottle washer to coming here to talk to you? Something like that?
But if you should be given a title, what would it be?
Oh, I have a very lofty title, my dear. It's called President and CEO.
Okay. which means you're in charge of the whole kit and caboodle. You have to make sure that it all works.
For 31 years.
For 31 years. Now, how did you join PALS way back then?
One of the early ladies came into my shop. I had the dumbest shop in the world called Contours on Parliament Street, and we used to do the medical fittings of the collars and the back supports and the breast prostheses, and said they were starting up PALS and would I like to come along, and that was in April, and by August I was taken over the head of it.
You gave up your business?
Not till 1995.
Oh,
yeah, this was early in 83.
Now, what attracted you to PALS?
Well, I am a nurse by profession. I do not, mercifully, that I know of, have cancer in my immediate family. I don't know, it just seemed a way to help at the time.
We're almost to the end. Your nurses, do they get ongoing training in terms of cancer?
2 go away every year.
Okay.
For training, and 2 have just come back from Boston, and they said it was the best course they've ever been on.
Yeah. Now, in my work at the hospital, I do get a chance to rub shoulders with your nurses, and I find that they are some of the most caring individuals. As I listen to them, they will go in the home, and they even get an opportunity to know the family. Sometimes in listening to them, they become one of the members of the family.
Absolutely.
And their work is so tremendously appreciated.
Well, we do whatever needs to be done. When we get a referral, they will go in and make an assessment, and then make a care plan if they're going to see the patient once a week, once a month, every day, 3 times a week. Every case is different, and whatever that patient needs, we try to give.
Now, in selection of your nurses, how do you do that?
Well, first of all, I tell them they can have all the degrees and letters behind their names, but if they don't have it here, they ain't going to be a PALS nurse.
And let me tell you, those that I know, they have it right here.
Yeah, they have to.
Yeah.
And in the office, the girls, I have 2 office assistants, and the patients and their families are always coming in for food supplements and dressings and whatever they might need, and so we all get to know lots and lots of the patients.
Yeah. Well, Mrs. Ann Smith-Gordon, I think Bermuda appreciates the work that you're doing, and we look forward to being able to help you in whatever way we can. And we thank you. We will come back right after this with another one of our guests. Welcome back to Issues. In our first half, we spoke with Ann Smith-Gordon of PALS, very interesting lady, and we heard how much PALS is really committed and dedicated to cancer treatment here in Bermuda. Well, we're now going to talk with Dr. David Green, who is with Bermuda Cancer and Health. And welcome, Dr. Green. I'm so happy to have you.
It's good to be here. Thank you.
My first question, what year was Bermuda Cancer and Health founded, and for what reason?
I believe it was founded in 1945, and it's one of the earliest non-profit charities that was around at the time. And it was really founded to assist people with TB, and the original title was Bermuda Cancer, TB and Health, because TB obviously was a big player in those days. But as TB became less prevalent, the TB aspect of the title was dropped, although a lot of people, particularly elderly people, still know it as Bermuda Cancer TB. So in more recent years, we've concentrated on our breast imaging general ultrasound imaging, and diagnostic testing. But also we offer support in educational facilities for the patients that we see. In fact, in more recent years, we've become a more breast specialist centre, and we now expanded to offer breast biopsy services, both ultrasound and mammographic guided, and that's been a great advance for us.
Digital mammography. What's the
mammography?
Mammography.
Yes.
Right. I believe in the recent years you've added that. Now, what does the digital mammography show that regular would not?
Well, first of all, let me explain what we had before, which was just plain film mammography, a bit like any X-ray, which is an X-ray of the breast, and you pop it up on a light box to view it. You develop it like a film in a camera. And because of that, there's many parts in that process that could go wrong, and you get a suboptimal film, and you'd end up repeating the film. And often the radiation dose involved in getting a good diagnostic test was quite high. But with digital mammography, it's been a great advance because the radiation dose of the breast was halved. There's no nasty chemical to develop the film. There's a lot more latitude in the exposure. So if you don't get the exposure quite spot on, the film is still diagnostic because you can manipulate the image electronically to make it still a viable film. So it adds a lower radiation dose. It's been shown that it also provides more diagnostic information in the image because it's a better contrast on the film and you see more information in the image. So you're basically able to diagnose more cancers.
And that's where my next question was going to lead. Since you've brought digital mammography in, are you being able to diagnose more breast cancers?
Historically, the answer is yes to that. When I came here 2.5 years ago, we already had digital mammography. But certainly in those countries where it was established, there was an increase in numbers of cancers being detected by mammography, by digital mammography compared to the conventional plain film mammography.
Now, a few months ago, all over the media, we saw Angelina Jolie.
Yes.
With that exposure to the news, have you seen an increase in women coming in to get their breasts tested?
Actually, yes, I think we have. Perhaps I could just sidetrack a little bit and say 95% of breast cancers are spontaneous. It's just unfortunate. It's a common disease, and ladies get breast cancer. But 5% have a genetic component, and I believe Angelina Jolie fell into that 5% category. That means you're carrying an abnormal gene or genes that predispose you to breast cancer at an earlier age. And if you're a gene carrier, you can test for this now, then your risk of breast cancer can be as high as 80%, and also there's an increased risk of ovarian cancer too. So ladies who have the gene, who've been tested and know they have the gene, have some difficult decisions to make, including Angelina Jolie.
How early can a woman be tested to see if they have the gene?
Well, it's done by a simple mouth swab because you're looking at the genetic code inside a cell. So in theory, you could do it from day one after being born. And maybe in the future, everyone will be gene tested and everyone will know what kind of problems they might stack up in the future. But in essence, what happens, 95% of patients are not going to be gene carriers, so you can't really test them all currently. There's no need to. So we look at the family history of patients when they come for breast screening. We ask them about their family history. If you're a gene carrier, the chances are you have a strong family history of breast cancer or ovarian cancer. And if they put that forward to us, we can advise them about whether they wish to avail themselves of the opportunity to be counselled. We have a free counselling service on Bermuda cancer by a visiting expert from the US who comes every few months. And it's a free access clinic. If the patients answer a questionnaire, it's sort of read to determine whether they're likely to have a strong family history or not. And if they are invited to come for counselling, and then a decision is made whether to offer gene testing or not.
Okay. Now, what determines whether a breast needs to be removed or not?
That's a very complex topic. And as a radiologist, I can give you a radiologist's opinion, but really it's a surgical decision and an oncology decision. But essentially, it depends on the size of the cancer in your breast, where in the breast it is, because the closer to the nipple, the more likely it is you need to have more extensive surgery. And the reason for that is the lymphatic drainage is very strong closer to the nipple, and cancer spreads by the lymphatics as well as the bloodstream. So the chances are it spreads early if your cancer is close to the nipple, and one of the safest options in that case may be to remove the entire breast. But if you have a small tumour in a large breast, in fact, in most cases you can get away with what's called a lumpectomy, just removing the abnormal tissue and leaving the breast intact.
Now, I would imagine that there probably is a lot of psychological reaction when a woman finds out that she has breast cancer. In your experience, how is this dealt with? And to what degree do you think it would affect the family and especially the husband?
Sure. One of the reasons why I was brought into Bermuda Cancer and Health is because I was trained as a breast specialist radiologist, and what that title means is we're not backroom staff as radiologists. Traditionally, a radiologist sits in a dark room looking at x-rays, doesn't talk to patients, doesn't see patients. But a breast specialist radiologist is different in the sense that they are dealing with patients face to face all the time. Now, for those patients who come for screening mammography and it's normal, they probably don't get to see me unless they want to.
By the way, sorry to interrupt you, but sure. that was a question that my wife asked me to ask you because today I know I was going to interview you. So I said to her as we were driving home, have you ever seen Dr. David Green? She said, who is Dr. David Green? So if they see you...
It's good news if they don't know who I am and never see me, because it means they're normal.
Okay.
If they have a problem, then they usually get to see me and I explain the nature of the problem and what we can do about it. Okay. I would say that if patients, they don't have to be coming to us for imaging. If they just want to talk to someone who deals with breast disease, they can phone up and make an appointment. I'll talk to them. And we do that quite frequently, and there's no charge for that.
Okay. Now, would you have any type of statistics concerning cancer or breast cancer that might be relevant to Bermudians?
Absolutely. Generally, worldwide, breast cancer is a common disease. There's a lifetime risk for general population of women of about 1 in 12.
1 in 12?
In fact, it's getting worse. In some countries, it's now 1 in 8, 1 in 9. Okay. But there are subsets of patients, and it seems to be black Afro-Caribbeans that the risk of cancer occurring at a younger age is increased.
Okay. So let me get this straight. Some women are predisposed because of genetics.
Yes.
And there's very little that can be done about that if you happen to have the genes.
Yes.
Now, the other 95%, is it bad health? Can it be prevented? Basically, that's what I'm getting at.
The current state of play, no, it can't be prevented. But the way we fight it is early diagnosis, and the early diagnosis is provided by screening mammography. So screening mammography is a very important technique. We encourage women to avail themselves of the opportunity to take it up. In fact, Bermuda's got a very high acceptance rate. Traditionally, if it's said if you have 70% of the eligible population accepting their screening, then you're going to make a difference to the mortality. But in Bermuda, about 87% of women accept their invitation, which is a very high rate indeed, and they're obviously very keen to avail themselves of that important health screen.
Now, individuals who are diagnosed with breast cancer, can it be treated here locally, or do they have to go overseas?
Absolutely here.
Okay.
I don't work in the hospital, but I see the people that do at a tumour board meeting that I attend every week. So I get to know the personalities involved, the oncologists, the surgeons, the pathologists. I've been exceptionally impressed with their skills. Not that I would expect otherwise, but you come to a small island, and somehow in the back of your mind you think, well, maybe they're all, backward or something. I don't know. But they've got the skills and the talents of anybody, any expert in the world. They really are top notch. So for the standard routine stuff, they're more than able to deal with that. I would say that if you need more complex surgery like reconstruction and so on, they probably don't have those skills, and that's the time when you would need to be referred overseas.
Okay. Now, for families who are watching, are there symptoms, are there telltale signs that a woman could use to say, well, I really need to go in and get tested?
Yeah. So there's two categories of women. There's the screening women who don't have any symptoms, and they, in this country, should start screening with mammography at the age of 40, and traditionally it's an annual screen after that. For women and it's also recommended that they become what's called breast aware, where they're examining their breast periodically, fairly frequently, for any potential problems. And then you have the symptomatic women who have breast symptoms, and they should go to their general practitioner. But what they should look for, several things. Inside the breast tissue, you're looking for a lump. So if you do breast examination, you're probably the first person that's going to find the lump rather than your doctor. If you have localized pain and tenderness, that's often not a significant sign, particularly if it's cyclical, comes and goes with your menstrual cycle. But if it's persisting and localized, that might be significant. So a lump and pain, changes on the nipple discharge, skin distortion or puckering, skin excoriation on the nipple, they all may be significant signs, that may often not, but that's when you should go to your doctor. And if you have generalized skin changes over your breast, skin puckering or distortion when you examine yourself or look in a mirror, that could be significant as well.
And you said age 40 is about the first time a woman should start testing.
If they're in that general risk population, if they're known to be at high risk either by their family history or they've already had the gene testing, then we would recommend an earlier start to their screening.
Okay. Now, Dr. Green, having been here in Bermuda and having worked overseas, do you find the reaction of women here to breast cancer similar to women where you've practiced before coming to Bermuda?
It's a universal disease, and actually the response to it is very commonly universal too, whichever areas I've worked in. The first concern is, do I have cancer? Everyone that gets called back, if I read a mammogram and I think it potentially might be abnormal, then I call them back for further imaging. Actually, most times, perhaps 9 out of 10 times, it will be to prove it's normal. But they don't know that. They assume the worst, so they come very fearful, and they're very grateful when you're able to say everything's fine. But they go through a lot of emotions, and it's a very difficult time for them. I try to talk them through it and allow them to have time to ask me questions. Sometimes it's difficult. Sometimes it's obvious the patient wants to know up front, black and white, is this cancer?
Yes. Yeah.
Sometimes it's clear from talking to them, they kind of want it given to them gently. So in which case we try and do that, and over a period of time plant the seed in their head that there might be something significant, and build on that until they are receptive to what you're going to tell them. Because an awful lot of time you're giving them bad news, they're not receptive to taking that in, and they go out of the door. Which is why it's important to have family with them, because you've got an extra pair of ears and eyes that can ask me questions and take the news in.
And so. Are you the person at Bermuda Cancer and Health that's responsible for giving the bad news?
We do the biopsies and we send the results off to the doctor. Now, I try to give that patient my opinion, what it's likely to be before we know what the actual result is. So if I think it's going to be a cancer, and often you can be pretty certain, I try to pre-warn them. But I always say to our patients, if you need to talk to me again when you've got your biopsy result, I'm here, just come along. And it is a skill that you need to learn to impart bad news. And some days you get it right, some days you get it wrong. I'm still learning. But it's an important service to offer patients, because they're most vulnerable and they need time and comfort, really.
Okay. Thank you so much, Dr. Green. We have been talking with Dr. David Green. He is the radiologist at Bermuda Cancer and Health. And by the way, we had a previous program where we had one of his patients on, and she just spoke marvelously about Dr. Green. In fact, that's what indicated to me that I really need to see this person and interview this person. So, Dr. Green, we're very happy to have you in Issues, and we will see you next time.